Bismillahirrahmanirrahim. Assalamualaikum and good morning everyone. We are from DVM5, rotation group 16 and 6. We'll be presenting a case of pancreatitis in a toy poodle. So this is Om, a 9-month-old male toy poodle weighing 3.4 kg with body condition score 1.5 out of 5. He is managed indoor as the only dog at home. His vaccination and deworming status is up to date. So for the history, around August to September this year, Om was brought to private vet multiple times with complaints of inhabitant, vomiting, and abdominal pain. The vet prescribed antibiotics, gastric protectant, folic acid, probiotic, liver supplement, analgesic, and also NSAID. However, Om shows no improvement. And multiple blood tests were done and showed that Om had non-regenerative anemia, leukemia reaction, and increase in ALP. And other diagnostic tests such as SNAP4DX, Babesia gypsoni, and Leptospira antibody tests were also done and show all negative results. Then, on early October, Om was presented to UVH with complaints of inhabitant, melena, and abdominal pain. However, the dog's appetite and bowel were normal during hospitalization. And abdominal ultrasound was done and revealed that the gallbladder was enlarged and full of hyperechoic structure, suggestive of sludge inside it. Thus, Om was suspected as having cholangiohepatitis. And then, Om revisited UVH last Wednesday due to inhabitants and abdominal pain. Owner mentions that no vomiting or diarrhea was observed. And in 2 months, the dog has lost about 1.5 kg of body weight. Upon physical examination, all vital signs are within normal range except for pale mucous membrane and slight delay in skin tan. So, by taking into account of physical examination and the various test results from the history, the first problem list, which is pale mucous membrane, it could be due to non-regenerative anemia that could be caused by chronic inhabitants that lead to nutritional deficiency, such as iron and vitamin B12, that are crucial for erythropoiesis, or due to chronic inflammation or infection that could release inflammatory cytokines that would suppress erythropoiesis. Therefore, complete blood count and serum biochemistry was done to monitor progression of anemia. Next, the second problem list, which is inhabitant with occasional abdominal pain and history of gastrointestinal signs, could be a sign of pancreatitis or cholangiohepatitis. So the plans are to do abdominal ultrasound, canine pancreas specific lipase test, and also to cox feed with Hill's ID diet. Next, 5% dehydration from physical examination could be due to discomfort that causing the dog to not eating or drinking. So our plan is to maintain Om on IV fluid therapy.
Moving on to the diagnostic workup, from the hemogram results, we can see there is non-regenerative microcytic pneumochromic anemia due to chronic inflammations. And then from leukogram shows leukocytosis with neutrophilia, monocytosis, and eosinopenia, which may suggest leukemia reactions and stress due to chronic inflammations or infections. And from the serum biochemistry results, it shows low creatinine levels indicative of decreased muscle mass due to chronic inhabitants. Hypoalbuminemia may be due to chronic inhabitants as well. And hyperglobulinemia indicative of infections or inflammations. Increase in ALKP may suggest stress response due to chronic inflammations. So the abdominal ultrasound was done on 20th of October, where there's a presence of feel stomach, and duodenum, which does not correlate with the history of inappetence in O. And also there was also hypoechoic fat surrounding the pancreas, which where the typical findings for pancreatitis are thickening and hypoechoic pancreas parenchyma, and as well as hypoechoic pancreatic fat, which is correlates with the abdominal ultrasound finding here. And then next, we observe empty and small gallbladder as to compare with previous ultrasound done on 5th of October, where there's an echoic structure within the gallbladder suggestive of absence of sludge, and mild edematous gallbladder suggestive of inflammatory, hepatic, and biliary disease, could be due to from when OM is recovering from the suspected cholangiohepatitis. So canine pancreatic lipase immunoreactivity test, CPLI, was done on the 5th and also 20th of October, where on the 20th of October, we can see that there is an abnormal finding of the canine pancreas specific lipase enzyme test, which suggests that there is a presence of pancreatitis, as this is the most commonly used blood test for pancreatitis due to its high sensitivity and specificity in dogs according to literature. So for the updated problem list, for the first problem, pale mucous membrane, we cannot rule out both differentials because a non-regenerative anemia could be due to inappetence and concurrently with the chronic inflammations and infections. And for the second problem list is the inappetence with occasional abdominal pain. We rule based on the clinical signs, the CPLI, as well as the abdominal ultrasound, we rule out cholangiohepatitis. And then we rule in pancreatitis. And we continue with coax feeding on with ID diet. For the third problem is the 5% dehydrations that could be due to inappetence. We continue with IV fluid therapy for all. And for the last updated problem list, which is the leukemia reactions, could be due to severe infections or inflammations due to pancreatitis conditions. We start OM with antibiotic therapy. So the tentative diagnosis for OM is pancreatitis.
For the treatment plan for this case, as our main problem is pancreatitis, Om was maintained on IV fluids throughout the hospitalization as he was not drinking or eating on his own due to the pain from the pancreatitis, as well as having the dehydration status of 5%. And then morphine was given 0.3 mg per kg intramuscularly 3 times per day from day 1 to day 4 as an analgesic for the abdominal pain due to the pancreatitis. And on day 5, the analgesic was changed from morphine to tramadol 4 mg per kg subcutaneously. Papes was also given 1 tab orally twice per day as an anti-inflammatory to ease the discomfort from the pancreatitis. So, oops. Okay, so for the second problem, which is in appetence, B complex 1 type orally was given twice per day from day 1 to day 4. From day 1 to day 6 as an vitamin supplement for metabolic function as well as appetite stimulant. And then metazapine was also given from second day to day 4 as an appetite stimulant as well. And was fed with Hill's IE diet as a low-fat nutritional support. Then for the third problem, leukemia reaction is treated with amoxicillin 15 mg per kg intramuscularly every other day as a broad spectrum antibiotic for the infectious complication that can arise from pancreatitis. And lastly, for the non-regenerative anemia, parasite was given 1 tab orally once a day as an iron supplement for erythropoiesis. Blood transfusion was planned but not done for this case due to the donor that the owner brought over to UVH was not compatible, and it was observed that on PCV was stable for the past few days of hospitalization. And for the case progression for this case, so during hospitalization, patient has shown good appetite whereby OM wants to eat OM wants to eat by cox feeding for day 1 to day 5, and then eventually wants to eat on its own on day 6. So during hospitalization, there was no abdominal pain observed as well as vomiting and diarrhea. The dehydration for this dog was improving from having the skin tan of 3 seconds upon presentation to becoming less than 2 seconds throughout the hospitalization. However, the problem of pain mucous membrane still persists. So for this problem, IV fluids was changed from having replacement rate with 5% dehydration taken into calculation to becoming just maintained on maintenance rate. So for the PCV of this dog, it remained constant and did not drop any further from 20% on Thursday to 21% on Friday, Sunday, and Monday. Patient was eventually discharged on Monday, which is on day 6 of hospitalization, and blood transfusion was postponed until donor is available for this dog. So in this case, the prognosis could be good as has showed slowly regaining his appetite. His PCV did not drop any further, and signs of pain in this dog seems to be reducing as well. And based on literature, prognosis is good even for end-stage pancreatitis. However, for this case, it could be fair as the owner has shown previously that they failed to comply to the treatment plan to be given at home. Plus, the progression of leukemoid reaction and non-regenerative anemia might be out of control, and pancreatitis could flare up easily, such as simply by giving oily diet. So the client education for this case is firstly to take into account is giving proper diet. So giving low fat diet for pancreatitis management is important, and examples of recommended diets such as Hill's ID diet, Royal Canin gastrointestinal low fat, or Yucca Nova intestinal diet. Second, owner compliance is also very important for this case, such as it is important for owner to give and finish the medication as prescribed to ensure better progression and prognosis for this case, as well as do not give fatty treats and diet for this animal. And lastly, close monitoring of the patient is also very important, such as a owner needs to monitor for any possible signs of flare-up, such as inappetence, vomiting, diarrhea, and for any signs of abdominal pain or anemia, such as lethargy or pale mucous membrane. And if there is any signs of this seen in the animal, owner is advised to immediately bring it to the vet. So that is all from us. Thank you. Is there
Hi.
any questions? Sorry.
Yeah, I have a couple of comments. One is regarding your non-regenerative anemia. How long has this dog not eating?
This dog has not been eating since August, since being brought to the private vet, so it's around 2 months.
I don't think it can be completely anorexic, right, for 2 months? It's hyporexic.
Yeah, we agree.
Okay. 2 months of hyporexia, I mean, what you're saying for your differentials for non-regenerative anemia is inappetence. That's incorrect. And I don't want people to get into the habit of giving that as a differential for non-regenerative anemia. A microcytic a hypochromic anemia, which is iron deficiency anemia, is seen with chronic blood loss. And if there's chronic emaciation, this is not seen with inappetence. So please don't, I don't want any people in the future to give that as a differential. So when you give it, when you have a non-regenerative anemia, you know that there is something inflammatory process going on in this dog. You can just put tentatively, you think this is because of anemia of chronic disease. That's okay. You don't, because you feel you have to add more than one, then you put things which are incorrect. Please be careful. Then with your ALP elevation, you said that's because of inflammation? Initially, you said there's an elevation ALP and you think that's because of inflammation. That's what you said, correct? Hello, group?
Yes, but most probably due to stress response, due to the
No,
chronic.
there's no such thing. No, 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 no. Again, you're missing the main point. When you see an elevation ALP, the first thing you should think about is, could this be a extrahepatic bile duct problem? right? That's what you think about. Of course, yeah, it could be elevations because of bone ALP in young dogs. Yes, it could be elevation because you have a Cushingoid dog. But really, you shouldn't be thinking, oh, this is because of stress. No, that means virtually any case which with stress, you should see elevations ALP. Do we see that? No. So that's why you should immediately think, oh, is this possibly an extrahepatic problem? And then you should start working it up. And lo and behold, you found out this dog had pancreatitis, okay? So be very careful with your interpretation. You can't start blaming everything on stress, inflammation, infection. Think carefully. Those blood results, those values are telling you something, telling you which direction you should go, okay? So just be very careful about that.
Okay, Doctor. Initially, we thought that it could be due to extra hepatic problem, but based on the
Yeah,
blood
you have
result,
1,000. You have 1,000, you know, 1,440. It's not a joke. You're gonna see that. You should immediately think about extrahepatic problems. Okay. All right.
yes, but
I have one more question. When you already found that there was evidence of pancreatitis on an ultrasound, why was the CPLI done?
Doctor, we did CPLI first before abdominal ultrasound.
Oh, okay. That makes sense because when you presented it, you presented the CPLI later. So usually if you see changes on the ultrasound, that's diagnostic enough. All right. But CPLI, when you don't see changes because it's acute changes, you may not see anything on ultrasound. That's when you need to do CPLI because CPLI is more sensitive. And then my last point is you at the end you said your tentative diagnosis is pancreatitis. Yes.
Yes, doctor.
Why is it tentative? You did CPLI, it's abnormal. You have those abnormal changes on the ultrasound. Why is it still tentative? You're still not sure, is it, that it's pancreatitis?
sorry, Doctor. It should be definitive diagnosis, Doctor, based on
Yeah,
the.
so just be careful. Tentative means tentatively this is what we think it is. We just don't have sufficient evidence to prove it. All right? But this is final diagnosis, pancreatitis. Okay, thanks. That's all from me.
Okay, Doctor.
Are there any more questions? If there are no any questions, shall we proceed to the next case?
Yeah, just go on then if there are no questions.
Okay, thank you, doctor.
A moment. have some technical issues. Please hold on. A very good morning to all. We are from rotation group 16 and we will be sharing a case of hematochezia in a chronic kidney diseased Persian queen. Okay, meet Gracie. She is a 12-year-old Persian weighing 2.8 kilograms with a body condition score of 2 out of 5. The vaccination status is not up to date. However, the deworming status is up to date. And she is managed in a multi-cat household with 3 other cats and fed with greens kibbles. So the history for Gracie was that initially on 27th of September this year, she previously came to UVH with complaints of 1 to 2 months on and off bloody diarrhea of score 1 to 2 and for oral biopsy, and the result was infundibular and follicular cyst. She was then diagnosed with CKD and bilateral malassezia otitis. So the previous medication dispensed to her was Surolan eardrop, kaolin pectin, Digestrong, Azodil, and Drontal. So on 12th of October this year, she came back again and owner complained of worsened hematochezia since yesterday, inappetence for the past few days, and weight loss from 3.1 kilograms to 2.8 kilograms. So the other reason for visitation was to reassess her CKD. So attached below are the pictures from the owner showing the bloody diarrhea, hematochezia. Just to share, this is the abdominal ultrasound from the previous visit to UVH, showing the ultrasound finding of indistinct corticomedullary junction and slight corrugated cortex, showing suggestive of chronic kidney disease. However, the kidney size was ranging above 3 cm bilaterally, showing normal kidneys. The urinalysis from the previous visit was also available, and the urine SD was 1.02, meaning that it is minimally concentrated urine. The urine pH shows 6.5, which is acidic urine. However, the protein and ketone were negative. The fecal examination from the previous visit was also not significant. Another CBC and SBC was done at the private vet at 6th of October before it was admitted to UVH, showing elevated urea and creatinine. Indication was azotemia indicating renal disease, and there was hypoproteinemia due to hyperglobulinemia. Okay, so upon presentation to UVH, the physical examination was done, and she showed that she was hypothermic of 37.8. However, the pulse rate and the respi rate was normal. And other than that, the mucous membrane was pale of CRT 2 seconds. No fleas and lice were identified. It had clear lung sound, no abdominal pain upon palpation, and the bladder was small. The bladder was small in size, and the valve with closed vulva. So the problem list for this particular cat was the hematochezia and diarrhea, with the differentials categorized into non-infectious and infectious. Under non-infectious, we have listed uremia due to CKD, colitis. It could be inflammatory bowel disease or neoplasia of the lower bowel, such as adenocarcinoma or lymphoma. For infectious, we listed parasitic, could be giardiasis, ancylostoma, tapeworm or roundworm, virus due to FIV or FALV, and bacteria due to E. coli or salmonellosis. So the further diagnostic plan for this particular cat was to do a follow-up CBC and SBC, abdominal ultrasound, fecal sample to be sent to parasitology lab, bacterial culture, FIV or FELV test, quick PCV and PP, and endoscopy. The renal azotemia was already apparent, so the diagnosis was already done. So CKD of chronic kidney disease. So the further plan for this was to reassess the CKD. Therefore, we plan to do CBC and SBC, an updated abdominal ultrasound and radiograph, urinalysis, blood pressure monitoring, and give fluid therapy. So for the third problem, inappetence could be due to problem 1 and 2. So the further plan would to cox or force feed.
On to the diagnostic workup. On the 12th October, complete blood count was done, and from the hemogram we can see there is anemia masked by the where we can see the hemoglobin at the side and PCV were on the low normal side. Next. From the leukogram, we can see there's leukocytosis and also regenerative neutrophilia.